we pass to a new target against the hyperlipidemia, Professor Bertolotti.
Thank you. Okay, and thank you very much. And first of all, let me also thank Professor Leo Fabbri for inviting me to take part in this highly prestigious meeting and for giving me the opportunity to share with you some aspects of this stimulating and innovative approach in the treatment of hypercholesterolemia. And what I will do in the following 20 minutes will be to briefly summarize some aspects of the regulation of cholesterol homeostasis, and then to stress the role of PCSK9. And fortunately, I only have one target, and not many others like the other speakers did. And then I will mainly focus on the clinical evidence on the efficacy of PCSK9 antibodies as innovative cholesterol-lowering agents. Well, cholesterol balance in the liver is tightly regulated by a very complex interplay between input and output pathways. And among the input pathways, of course, endogenous cholesterol synthesis and the internalization of LDL via the LDL receptor. We will focus mainly on this. This is obviously a main target in lipid-lowering treatment. Maybe the most efficient mechanism whereby the liver disposes of cholesterol is production, degradation to bile acids. So intercellular cholesterol concentration is regulated homeostatically by a very complex balance between these input and output pathways, which are capable to influence each other. And this is made possible by the presence and the function of very fine and delicate mechanisms of sensing of intercellular levels of lipids. SCAP is actually, this protein is a sensor of the content of lipids and cholesterol in particular inside the cell. And for instance, when the cell needs lipids, needs cholesterol, SCAP can drive this transcriptional regulator, SREB, inside the nucleus, where SREB in turn can activate the transcription of the number of target genes. In the case of cholesterol, for instance, the isoform SREB2 is the one that comes into play and activates a number of enzymes which are involved in cholesterol synthesis, like HMG-CoA reductase and HMG of cholesterol to bile acids, for instance, with the resin, which increases the output of bile acids in the feces, the cholestyramine. We derepress, we increase the synthesis of bile acid, the cell needs more cholesterol and then activates the LDL receptor pathway. The higher the synthesis of bile acids and the lower the levels of LDL cholesterol. We knew it worked, and now we know very well the molecular mechanisms underlying this phenomenon. And for statins, it's almost the same mechanism. We see here, of course, the primary intervention is on by cholesterol synthesis. Statins inhibit competitively HMG-CoA reductase, and once again the liver reacts by activating the LDL receptor pathway, so the internalization of lipoproteins via this particular pathway. And this represents, of course, the main hypercholesterolemic mechanism of statin drugs. Well, statin drugs, as we know, are very effective. They are wonderful drugs. They are effective and very well tolerated. But nonetheless, some issues are still present. First of all, the difficulty to reach adequate LDL cholesterol levels in high-risk patients, in critical patients, and also the issue of statin intolerance, which a number of patients can experience. In order to overcome these unresolved issues, of course, innovative approaches are welcome, and the question is it possible to manipulate intercellular cholesterol metabolism, and preferably in a non-homeostatic way, I should add, in an alternative or adjunctive way to statin drugs. And of course, the final objective is still that to increase the expression of the L receptor and so to facilitate the internalization of LDL cholesterol. And here in the past few years, the focus has been posed on this protein, which is kind of difficult to spell out anyway. We will call it PCSK9. And we will see what the role of this protein is. In normal conditions, as we said, internalization of LDL is largely a receptor-mediated process. And after endocytosis, the LDL receptor can recycle to the surface of the liver cell and so can be actively reutilized. What PCSK9 does is, as you can see in this cartoon, it is synthesized inside the cell, then it's extruded in the extracellular space. It interacts with the LDL receptor complex, and inside the endocytic vesicle, it catalyzes proteolytic degradation of the LDL receptor. So in other words, the activity of PCSK9, if PCSK9 activity is increased, we have less LDL receptor molecules available for the cell surface. So we are expected to have a hypercholesterolemic phenotype. On the other hand, if PCSK9 is inhibited, we would expect to have more LDL receptors available on the cell surface and then to lead to lower circulating cholesterol levels. And actually, this view is confirmed by a number of spontaneous models in human disease. This slide shows you the description of a new gain-of-function mutation in the PCSK9 gene responsible for a form of familial dominant hypercholesterolemia, which is now called as ADH3. Autosomal dominant hypercholesterolemia type 3, exactly as in a very similar way as the other forms, receptor defective or ApoB defective. Even if this form is not very prevalent in the general population, but I think this represents a very interesting and stimulating model. And also, variants and polymorphisms of PCSK9 have been described who can influence the level of cholesterol and also the severity of atherosclerosis in polygenic hypercholesterolemia. So not strictly familial forms of hypercholesterolemia, but the forms that we commonly see in our clinics. On the other hand, loss of function mutations of PCSK9 are associated with the phenotype of hypocholesterolemia, which is virtually undistinguishable from either other genetic forms of hypocholesterolemia like familial hypobeta-lipoproteinemia. And here again, mutations and variants of PCSK9 have been described who are associated with lower plasma LDL cholesterol and also lower prevalence of coronary artery disease. So, of course, with this pathophysiological basis, PCSK9 stands as a very attractive target for drug companies. And in fact, a series of human monoclonal antibodies have been devised versus PCSK9. In the following presentation, I will focus mainly on alirocumab and evolocumab, for which a huge body of evidence is presently available, but other drugs are on the way as well. So let's figure what the impact of these monoclonal antibodies can be. The monoclonal antibody binds to the PCSK9 and prevents PCSK9 from being internalized and from acting its proteolytic action on the LDL receptor. So as a consequence of the blockage of PCSK9, of course, more molecules of LDL receptors are available for internalization of cholesterol. Now let's start from the first phase 2 studies. This is a study published a couple of years ago with alirocumab, the Sanofi drug. It was a phase 2 study, and it was done on hypercholesterolemic patients already on treatment with 10 milligrams of atorvastatin. Then, as you can see, one arm of the study received an 8-fold dosage of atorvastatin, reaching an additional 20 to 24% decrease in LDL cholesterol, and the other two arms received alirocumab with either 10 or 80 milligrams of statin. And as you can see, regardless of the dosage of statin, we had an almost 50% incremental decrease compared with the simple increase in statin dosage. This is another phase 2 study still with alirocumab. This is a dose-finding study, different doses and different schedules of treatment, but once again, an average decrease around 50 to 60% in LDL cholesterol. And these are findings from the phase 3 studies with evolocumab, the Amgen drug. This was done in heterozygous familial hypercholesterolemia. Most of these studies have been done on top of lipid-lowering treatment with statins, obviously. And here's, once again, with two different evolocumab dosages, you can see a nearly 60% decrease in LDL cholesterol throughout the study. This, as far as we know, is the only study performed on homozygous familial hypercholesterolemia, a condition which is particularly critical to deal with. And here you can see not a 60%, but a 30% decrease with evolocumab. And for those of you who know this field, 30% decrease in LDL cholesterol is a huge decrease. It's very relevant in this critical form in homozygous familial hypercholesterolemia, still on top of lipid-lowering treatment. And also we have a body of evidence with these drugs in monotherapy. And most of these studies have compared the PCSK9 antibody with ezetimibe. As you may recall, ezetimibe acts by blocking intestinal cholesterol absorption, so it's another target, another point of attack of hypolipidemic drug. As you can see in the slide, ezetimibe could attain about a 20% reduction in LDL receptor, which is what we expect from the literature, versus the, once again, nearly 60% decrease in LDL receptor with evolocumab. The same is virtually true with alirocumab in monotherapy versus ezetimibe, nearly 20% with the absorption blocker alone, 55% with alirocumab. And this study was done specifically in patients with statin intolerance. That, as we said before, is one of the problems still present with the statin treatment. And once again, the similar results, 20% decrease with ezetimibe and nearly 60% decrease with both dosages of evolocumab. These are the two more recent studies, and for the first time we take into account also hard clinical outcomes. This was published in the New England Journal of Medicine about a year ago, in April last year. And as you can see, in association with the expected 55-60% reduction in LDL cholesterol, for the first time, treatment with evolocumab was associated with a significant reduction in events, in cardiovascular events. And in the same issue of the New England Journal of Medicine, another paper, this time with alirocumab, showed very similar results, comparable decreases in LDL cholesterol and a significant, even if this was not a primary endpoint, it was a post hoc analysis, but the results were all the same highly significant from the clinical point of view, a reduction in major adverse cardiovascular events. And the only side effect in this particular paper was the prevalence of myalgia, which was increased in patients treated with alirocumab. This paper reports a very peculiar situation, and this is treatment with an antibody in this situation that I mentioned before, the gain of function mutation of PCSK9, where obviously this kind of approach targets directly towards the metabolic defects of the genetic condition, and here once again significant reduction in LDL cholesterol associated with the significant reduction in plasma PCSK9, which was measured in this paper. So even if the evidence on clinical outcomes is not so robust, we can see that for what we know now, PCSK9 inhibitors stay very well in line with the previously known evidence on statins, or they seem to perform even better from looking at this slide, even if clearly additional evidence with this particular endpoint is required. So a number of cardiovascular studies are ongoing, and they will be completed by the end of next year and the beginning of 2018 with evolocumab, alirocumab, and also with bococizumab, which I didn't have time to deal with in the present talk, but in the following 2 years we will certainly have more complete responses also in from what concerns the clinical outcomes. This slide, which was published a couple of days ago online, summarizes the main characteristics of PCSK9 inhibitors. As you can see, the indications are pretty much the same in non-tolerated statins, heterozygous familial hypercholesterolemia. These are the dosages. The bioavailability is quite good for both drugs, and half-life is around 15 to 20 days for both. The cost is not cheap, and this might represent, of course, one of the main drawbacks of these drugs. And the good clinical efficacy of alirocumab and evolocumab associates, fortunately, with a very good safety profile. This is a complete meta-analysis of virtually all the published studies on these two drugs. And as you can see, with alirocumab, there is a trend towards a reduced overall mortality. And the only significant increase in side effects associated with these drugs is the local injection site reactions. And also with evolocumab, the safety profile seems to be quite confident, with the trend towards a decrease in liver enzymes rather than an increase. And with none of these drugs, we could see from the literature increases in muscle enzymes, for instance. Both drugs have been approved by the FDA. Both drugs have been approved by the European Medicine Agency, and both have appeared on the Italian official bulletin of the legislation, and both drugs are presently underway and receiving consideration with the National Agency for Drugs for reimbursement policies. And we will know that in the following months, I think. So to conclude, and it's clear that systemic intracellular cholesterol balance is regulated by a tight and articulated mechanism of homeostatic control. The role of PCSK9 in modulating this control is very important and is beyond homeostatic control, is independent on the content of cholesterol inside the cell. And so far, the clinical experimental evidence with selective inhibitors of PCSK9 mainly as an adjunct to statin therapy, but also in monotherapy, is very encouraging, both in familiar forms of hypercholesterolemia in terms of efficacy and safety. Of course, as I anticipated before, the costs might represent an important drawback for widespread utilization of these drugs. And of course, additional evidence, long-term evidence, mainly in outcome trials will be needed. But they stand, in my opinion, as a very promising approach, particularly in critical patients. Thank you so much.
Thank you, Marco. Leo?
Thank you very much, Marco, for this overview. The efficacy of statins is believed to go beyond the effect on LDL, pleiotropic, and there is a lot of literature. Now, the question to you is, obviously this is excellent in lowering LDL. What is the evidence that is also equally effective in preventing the effects that you aim by lowering LDL, or that you believe are associated with lowering LDL?
Like, for instance, what kind of effect?
Cardiovascular, future risk, how much is the evidence accumulated? That's my question.
Oh, well, the issue of the pleiotropic effects of lipid-lowering drugs is a very relevant one, of course, and it's still an unsettled one, because many people still believe in pleiotropic effects, and others state that, and it's probably reasonable, that most of the so-called pleiotropic effects probably still rely on a decrease in cholesterol, even if they are not strictly metabolic endpoints. For instance, nitric oxide activation and so on. We don't know what is really the effect of statins, or which part of it is really mediated by the... And as you said, the concern of reaching too low levels of cholesterol, you mean? Of course, it depends on whether you are dealing with a patient starting from 300 of LDL cholesterol. Then, of course, if you reach very, very low targets, I don't think you are going to undergo side effects or other problems. And I don't know if you were addressing to some other particular aspects of lipid lowering.
No, the question is very simple. I mean, you obviously have an excellent biomarker of risk. And by addressing it with the monoclonal, you address the biomarker. You most likely, not the other potential effect of drugs.
Of course.
The question is that obviously you rely very much on the biomarker.
Of course.
But what is the evidence that in fact by acting so specifically on the biomarker then is also translating in an overall...
If it's true, as it's possibly true that many of the pleiotropic effects really are mediated by directly or indirectly by lower cholesterol levels, then we'll probably... But I agree with you, we definitely need more robust and stronger clinical evidence, and this will come, of course, only from the forthcoming studies, of course.
I mean, I think you showed the improvement in cardiovascular events, and of course, I mean that study tells you which of those patients with high cholesterol are the most responsive. I mean, can we pick up a biomarker that will indicate, because this drug is very expensive.
Yes.
I mean, who are those patients who the state is going to pay for?
No, of course.
I mean, I think that's a big question.
Yeah, this is probably the greatest question so far. And I think physicians will have to be very keen and very careful on focusing on which patients we have to treat. I think these will probably be patients with familial hypercholesterolemia who cannot reach satisfactory targets with the statins and who are still at very high risk, for instance, in secondary prevention. But I agree with you, the focus on the right patient will obviously, because these drugs will have to be taken lifelong or so, and so this will impact a lot on health expenses.
But to go on the point raised by Leo and Van, for statins, we know that not only cholesterol levels, but also CRP levels are predictors of response. So the best response on the clinical outcomes is in those patients who have high CRP and high cholesterol levels. So can you use CRP levels, high sensitivity CRP levels, to stratify your patients?
Well, CRP is maybe one of the little pieces that you can put into the mosaic. This is one. Lp(a) could be another one. And as you say, many pieces can make up your global cardiovascular profile of your patients. So a patient with high CRP might probably one in association with other markers that can benefit from these drugs. Maybe not CRP alone, but envisioned in a global vision, I think that would be very useful.
So that was a beautiful story, very well told, and it's an example of what is called black swan research. And I think this is a very, very potent type of research where it starts with a clinical observation, in this case a familial abnormality where the individuals affected had a profound biological effect, like one mutation causes a swan to be black instead of white. So this is one mutation causes a big effect.
Yes.
That protein then is mechanistically very interesting if you can identify it, and because you can easily block it.
Yes.
And I think this is a beautiful example of the future for me. If I were a young man, I would go into this field of genetics. And also a beautiful example of the importance of observing when you see patients, unusual patterns, unexpected observations, and trying to work back and work out what's going on. And we can all do this. I think it's why Leo, who's trying to put specialties together, get us out of our silos and talk to each other. And I think it's a fantastic initiative, and I've really enjoyed today. But we really do need to think much more broadly and out of our silos. So thank you very much.
Well, I completely agree with you, and keep considering that we are still young, you know. That's an important point.
Thank you, and thank you for the attention and